Chapter 10, Analgesic Drugs. Chapter 10, Analgesic Drugs. Analgesics are medications that relieve pain without causing loss of consciousness, often referred to as quote-unquote painkillers. You also are familiar with opioids and NSAIDs. Pain is whatever the patient says it is. It exists when the patient says it exists. An unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is a personal and an individual experience. Nociception is pain that results from stimulation of sensory nerve fibers called nociceptors. These receptors transmit pain signals from various body regions to the spinal cord and brain. Here's a nice figure for you on nociception. What is a pain threshold? It is the level of stimulus needed to produce the perception of pain in an individual. It is a measure of the physiologic response of the nervous system. Pain tolerance. Pain tolerance is the amount of pain a person can endure without it interfering with normal function. It does vary from person to person, so my pain tolerance might be less than yours or vice versa. It's a subjective response to pain, not a physiologic function. It varies by attitude, environment, culture, and ethnicity. So there are different classifications of pain by onset and duration. You have acute pain, which is sudden onset. It usually subsides once it's treated. And then you have chronic pain, which is persistent or recurring. It lasts 3 to 6 months, and it's often difficult to treat. There's different classifications of pain. There is somatic, visceral, superficial, deep, vascular, referred, neuropathic, phantom, cancer, and central. Make sure that you write out the definitions for each classification of pain. It's imperative that you understand and you know the differences between the pain and the classifications of pain. Pain transmission is tissue injury causes the release of bradykinin, histamine, potassium, prostaglandins, and serotonin. These substances stimulate nerve endings, starting the pain process. This probably sounds familiar from A&P. Body has endogenous transmitters, alkaphalins, and endorphins. Those are produced by the body to fight pain. They do bind to opioid receptors. They inhibit the transmission of pain. There's different treatments that we use in special situations. We often use a PCA pump, pain-controlled analgesia pump, patient comfort versus fear of drug addiction. So we often struggle with this because people are very afraid to take pain medications because they are fearful of becoming addicted to opioids, right? So we have to have a balance between keeping the patient's pain under control or keeping the patient's comfort level under control versus putting them at risk of fearing like they may become addicted to drugs. The key part in this is patient education. You need to explain to your patients about drug addiction and how it actually occurs and what our pain management program is and set for, and how we will make sure and prevent those addiction behaviors from occurring. We also have opioid tolerance. People do build up an opioid tolerance after long use of opioids. Use of placebos, recognizing patients who are opioid tolerant, and breakthrough pain. We're going to always treat breakthrough pain. We might have somebody who's in pain management and gets pain medications on a regular schedule, but they also might have to have a separate dose or even a separate medication prescribed in between the scheduled doses that they need to have accessible in case they do have breakthrough pain. Adjuvant drugs assist primary drugs in relieving pain. So those can, included in those are NSAIDs, antidepressants, anticonvulsants, and corticosteroids. So for example, adjuvant drugs for neuropathic pain would be amitriptyline, which is typically used as an antidepressant, but an off-label therapy that we use for neuropathic pain is amitriptyline. And then we also use gabapentin or pregabalin as those are both anticonvulsants, but we will also use those for neuropathic pain. Actually, gabapentin is widely used to treat neuropathic pain, but it is an anticonvulsant. Opioid ceiling effect is when the drug reaches a maximum analgesic effect. Analgesia does not improve even when higher doses. Opioid analgesics are pain relievers that contain opium. They're derived from the opium poppy or chemically related to opium. Very strong pain relievers such as codeine sulfate, meperidine, or Demerol, methadone, morphine sulfate, propoxyphene, hydromorphone, oxycodone, fentanyl, and many, many others. We have three classifications for opioid analgesics mechanism of action. We have the agonist, partial agonist, and the antagonist. So the agonists bind to an opioid pain receptor in the brain. They cause an analgesic response or a reduction of pain sensation. Here's a nice table that explains opioid receptors mu1, mu2, delta, and kappa. And you can see the different effects of the different receptors. Here is another figure just showing you the effects from the first pathway to the second pathway. Agonists and antagonists bind to the pain receptor, cause a weaker neurologic response than a full agonist, also called partial agonist or mixed agonist. Antagonists reverse the effects of the drugs on pain receptors, bind to a pain receptor and exert no response, also known as competitive antagonists. Here's a figure of naloxone reversing an overdose and how that happens. Opioid analgesics indications. So the main use is to alleviate moderate to severe pain, often given with adjuvant analgesic drugs to assist primary drugs with pain relief. Opioids are also used for cough center suppression, treatment of diarrhea, and balanced anesthesia. So it's important as you go along in this course in pharm to just make note sometimes or anytime, I guess, you hear me mention medications that are used for off-label uses, like opioids are used for cough center suppression, and opioids are used for treatment of diarrhea. Those are off-label uses. So don't be surprised if you see these medications not necessarily being used for pain, but for one of these other issues. Opioid analgesics contraindications. Known drug allergy, severe asthma, use with extreme caution, If the patient has respiratory insufficiency, why? Because we're going to have a depression in the respiratory system, just in general when we use these type of medications. Elevated intracranial pressure, you need to be very careful when using these types of medications. Morbid obesity, sleep apnea, or paralytic ileus. Opioid analgesic adverse effects include euphoria, CNS depression, which leads to respiratory depression. Most serious adverse effect, remember that. Opioid analgesics' most serious adverse effect is CNS depression, respiratory depression. ABCs, airway is our priority. Nausea and vomiting, urinary retention, diaphoresis and flushing, pupil constriction or meiosis, there's a medical term, write it down, make a card, constipation, and itching. Opioid tolerance. It's a common physiologic result of chronic opioid treatment. So somebody who takes opioids for a long period of time, guess what? They're going to stop working as effective as they were from the beginning. The result is we have to continue to increase the dose. Larger doses required to maintain that same level of analgesia. Oftentimes, this is what leads us to opioid addiction. So, we don't want to let our patients get to a level of opioid tolerance. We need to try to do some other things for pain management before they get to this level. Physical dependence, physiologic adaptation of the body to the presence of an opioid. Opioid tolerance and physical dependence are expected with long-term opioid treatment and should not be confused with psychologic dependence, which is addiction. A pattern of compulsive drug use is characterized by a continued craving for an opioid and the need to use the opioid for effects other than pain relief. This is psychological dependence. Opioids. So misunderstanding of these terms leads to ineffective pain management and contributes to the problem of undertreatment. Physical dependence is seen when the opioid is abruptly discontinued or when the opioid antagonist is administered. Opioid withdrawal, opioid abstinence syndrome, either one can occur. So, toxicity and management of an overdose, we're going to use Narcan for sure. Another medication that you may have heard of is Revia. So, either one of those medications are very commonly used. Narcan I see a lot being used in the ED, of course. These drugs bind to opioid receptors and prevent a response. They're used for complete or partial reversal of opioid-induced respiratory depression. Regardless of withdrawal symptoms, when a patient experiences severe respiratory depression, an opioid antagonist should be given. Patients will come out of their withdrawal so fast upon administration of Narcan. Sometimes you need to give more than one dose of the Narcan for it to do its reversal, but a doctor would guide you in that administration. Opioid withdrawal and opioid abstinence syndrome can occur. It is manifested by anxiety, irritability, chills and hot flashes, joint pain, lacrimation, rhinorrhea, diaphoresis, nausea, vomiting, abdominal cramps, diarrhea, confusion. Any of those medical terms. You do not know what they are. I need you to write an index card, look it up, and make sure you learn it. It's a figure of side effects. Non-opioid analgesics, acetaminophen. It is an analgesic and an antipyretic effect. It's available over the counter and in combination products with opioids. An MOA blocks pain impulses peripherally by inhibiting prostaglandin synthesis. Indications include mild to moderate pain, fever, alternative for those who cannot take aspirin products. For toxicity and managing overdose, even though it's available over the counter, lethal, it is still lethal when it's overdosed. Overdose, whether intentional or resulting from chronic unintentional misuse, causes hepatic necrosis or hepatotoxicity. Long-term ingestion of large doses also causes nephropathy. Our maximum daily dose for healthy adults is 4,000 milligrams a day, 2,000 milligrams for elderly or those with liver disease. That's important to remember. Inadvertent excess doses may occur when different combination drug products are taken together. Be aware of the acetaminophen content of all medications taken by the patient, over the counter and prescription. Very important. Interactions. Dangerous interactions may occur if taken with alcohol or other drugs that are hepatotoxic. Should not be taken in the presence of drug allergy, liver dysfunction, or possible liver failure. Herbal products. Feverfew. Related to the marigold family, it has anti-inflammatory properties. It's used to treat migraine headaches, menstrual cramps, inflammation, and fever. It may cause GI distress, altered taste, and muscle stiffness. It may interact with aspirin and other NSAIDs and anticoagulants. Nursing implications for analgesics. So before beginning therapy, perform a thorough history regarding allergies and use of other medications, including alcohol, health history, and medical history. Obtain baseline vital signs and I's and O's. Assess for potential contraindications and drug interactions. Perform a thorough pain assessment, including pain intensity and character, onset, location, description, precipitating and relieving factors, type, remedies, and other pain treatments. Assessment of pain is now being considered a fifth vital sign. Rate pain on a 0 to 10 or similar scale. Be sure to medicate patients before the pain becomes severe so as to provide adequate analgesia and pain control. Pain management includes pharmacologic and non-pharmacologic approaches. Be sure to include other interventions as indicated. Patients should not take other medications or over-the-counter preparations without checking with their physician. Instruct patients to notify physician for signs of allergic reaction or adverse effects. Opioid analgesic nursing implications. Oral forms should be taken with food to minimize gastric upset. Ensure safety measures such as keeping side rails up to prevent injuries or falls. Withhold dose and contact physician if there is a decline in the patient's condition or if vital signs are abnormal, especially if the respiratory rate is less than 10 to 12 breaths per minute. Check doses carefully. Follow proper administration guidelines for IM injections, including site rotation. Follow proper guidelines for IV administration, including dilution, rate of administration, and so on. Constipation. Okay, sorry about that. So constipation is a common adverse effect and may be prevented with adequate fluid and fiber intake. Instruct patients to follow directions for administration carefully and to keep a record of their pain experience and response to treatments. Patients should be instructed to change position slowly to prevent possible orthostatic hypotension. We have to always monitor for adverse effects. You're going to contact the physician immediately if vital signs change, patient condition declines, or pain continues. Respiratory depression may be manifested by a respiratory rate of less than 10 breaths per minute. Dyspnea, which is What? Difficulty of breathing? Write down that index card if you're not familiar with that medical term. Diminished breath sounds or shallow breathing. I want you to monitor for therapeutic effects as well. So these are our goals of our treatment. Monitoring for therapeutic effects. This is what we expect to happen. So we expect to see a decreased complaint of pain. We expect to see a decreased severity of pain. We expect increased periods of comfort, improved activities of daily living, appetite, and sense of well-being. We should also see a decreased fever with the acetaminophen if that's what we're using, and that's why we're using it.